which includes the laparoscopic part as well as the robotic aspect of it. Our session today would be chaired by none other than Abhideep Chaudhary, sir. Sir is also the president of the National Society of Liver Transplant, sir, if I am not wrong, sir. So, who better than you to judge our today's and be the chairperson for today's talks? Joining, sir, would be Ravi Mohanka, sir. Sir would be joining us soon, who would be chairing our session today. Our first talk would be about laparoscopic donor hepatectomies. So it sounds very complex, and I'm sure it is very complex. I mean, I personally have never seen a laparoscopic donor hepatectomy, but we have Dr. Balachandran Menon, sir. Sir, welcome, and thank you for accepting this invite to speak on this very complex topic. And we are really keen on watching and learning from you of these tips and tricks about the same. Welcome, sir.
Thank you very much, Akshay. Actually,
Yes.
we do both robotic as well as laparoscopic, but cost-wise and maybe convenience-wise, I prefer laparoscopic. But for ease of training, definitely robotic is better.
Sir, really waiting to watch you perform and wait for your presentation, sir. Meanwhile, sir, let me just introduce Dr. Gaurav Chaubal, sir. Sir, welcome, and we are waiting for you to present your experience about robotic hepatectomies. And I think that's the most talked about kid on the block. And robotic hepatectomy has come a long way. And looking forward for your presentation and welcome and thank you for accepting this invite, sir.
Thank you, Dr.
Sir. So I think without much waiting, let's start with Menon sir's talk. Menon sir's talk would be a recorded session, and sir would be with us online. So I think Himanshuji, if you can play Menon sir's talk and um, start his presentation.
Good afternoon, everyone. I will be speaking about laparoscopic donor hepatectomy. At the onset, I would like to thank ISOT for giving me this opportunity. So, laparoscopic donor hepatectomy, you actually don't need much new equipment apart from what is already available in most of the OTs, a good 4K system, a or a good 3D system. These are probably the only few extra instruments which you need: a snake retractor, a palpation probe, and just these 3-4 instruments, the gold finger, and they can be actually used for easily for 400 to 500 cases. So experience is the key here. As your experience increases, you find that the advantages go up, disadvantages come down. Skill and familiarity makes this process or this surgical procedure much easier. So these are the ports which we have been using. C and D is the most important. A little variation in placement of C and D, the surgery can become very difficult. D is placed just a couple of centimeters below the lower margin of the liver once you have inflated the abdomen. C is placed right in line with the gallbladder. So these are the 5 ports which are required. B, A and E can be 5 mm, C and D are 12 mm ports. So if you look at the advantages, cosmesis, yes, it's the most important thing because most of the donors are young, and most of them are actually very most of them are employed and leading busy lives. So cosmesis is very much important. Less pain, early discharge, less blood loss, early back to work has already been proved. Better physiological and psychological recovery is definitely seen with minimal invasive surgeries. Short-term benefit, yes. Long-term benefit, ultimately once the liver regenerates, apart from the scar, probably there is nothing much. But yes, psychologically and physiologically they are better, especially in the short run. Disadvantages, when you speak of disadvantages, the first question asked is it safe? Yes. As the numbers increase, probably it is much better than even open surgeries. Increased biliary vascular complications, All these things have been quoted, but as your numbers increase, they actually become the same or even less than open surgeries. In fact, the vascular and biliary stumps which you get with laparoscopic or minimally invasive surgeries is better than what you get with open surgeries. Minimal invasive needs excellent planning. You need to know the liver quality, the anatomy very well, and definitely the remnant. Experience and equipment and a good team is what matters. Low CVP, enough blood at hand, good anesthetist, and always loop the hilum to keep Pringles ready if required, especially in the early phase. So minimal invasive, there is definitely advantageous because of vision, better vision and precision. Keep the CVP low and the intra-abdominal pressure high, around 10 to 14. Use CUSA in the open mode. Suction is on, so the field remains clean. Now, the anatomy has to be very well documented. You can see here that there is a long right hepatic artery. The left hepatic artery arises from segment 4. The portal vein is single type A. The venous anatomy, especially the middle hepatic vein anatomy, should be known beforehand. You should know where the segment 5 is, segment 8, how many branches are there, and with experience you realize what is the depth of these vessels and how to actually reach them when you are doing the transection. So the steps of donor hepatectomy can be divided into liver mobilization, caudate dissection and right vein looping, hilum dissection, transection, and finally the duct cutting and cutting of the rest of the caudate. So first coming to liver mobilization. So I will be just showing videos for each procedure. You see with the palpation probe you can lift up the liver and everything is so well visualized. With experience actually it becomes pretty easy. The entire dissection can be done with the C and D ports, the 12 mm ports, and especially with experience you know which vessel can be tackled directly without clipping. Here you can see there is a quite a low inferior there which is actually small, so we can actually clip it off and divide. So unlike open, here the vision is much better and you know what to do. Now small branches you can directly use energy equipment. You see the division is done little away from the IVC, leaving behind a small stump so that it doesn't bleed and there is enough IVC to seal it off. So this is the mobilization of the liver, and you saw the right vein being looped and the Ryle's tube was passed across. In the upper part, mobilize the liver quite well, especially you should mobilize onto the left side as well, so that while doing the transection you can pull down the liver much better. So here the junction between the right and the middle is delineated and marked. The end is actually marked blindly, so here itself you can finish the marking. So next is hilum dissection. So hilum dissection definitely is advantageous with minimally invasive because you can see the vision is much better, and with experience this is actually pretty fast. So it's basically a very good cholecystectomy where you should take the cystic artery and the cystic duct with a good long stump so that you can hold on to them while dissecting the artery of the duct. So there two instruments retracting the cystic artery and the cystic duct, and here the artery is being dissected off the duct and the portal vein. You can see the triangle between the artery and the triangle area between the artery and the bile duct. You need to open this up fully. So the better you open this up, the easier will be the final duct cutting. So you see here it has been opened up well. Now the portal vein is to be looped. There is a small caudate which is coming in the way, so we are dividing the caudate. Towards the portal end side, ligating it, the distal end can be burnt off with harmonic. So That is the portal, right branch of portal vein which has been looped, and you keep it ready. The artery has been dissected off the duct. The entire triangle area between the portal vein, the artery and the duct is opened up widely. Next is marking of transection. Here the portal vein and the artery, they are looped, which has been already looped. They are clamped with plastic clamps, and you can see the transection line is being marked, and at this point ICG is given and it is reconfirmed with ICG. There you can see the ICG marking and the vascular marking which came in, they are both same. So next, coming on to the transection. So this was a case which was done 2 days back. Here you can see that there is this couple of segment 5 branches and there is a segment 8 branch. The portal vein is pretty good. So this was a case which was done couple of days back. You can see there are 2 branches of segment 5 and 1 branch of segment 8. So you need to know the anatomy well. So here the demarcation line is being marked just like before, and a suture is taken onto the right side. Left side retraction is with the gallbladder. So there the marking is fully done. Hilum, the right left junction is already marked when you are dissecting the hilum. Now you connect that. So initial part is done with the help of harmonic. So harmonic can be a bit tedious. So there you see it's the initial part being done with harmonic. Both sides, the right side is retracted with the gallbladder, left with the suture. So the initial dissection, as much you are comfortable, you can use the harmonic, then go on to the CUSA. Use CUSA in the open mode so that there is a bit of a continuous suction that keeps the plane clean. So initially we used to do this dissection with control of the right side using those bulldogs, but of late in the last 200 cases we have not been clamping the hilum. We are very comfortable doing without that. So you need to have good control of both right and the left hands and do simultaneous surgery. So presently we are able to do the transection in less than half an hour in most of the cases. So you see this transection was actually done in about 20 minutes, very little editing was required. So that is the segment 5. Most of the veins you need to approach posterior, anteroposteriorly, and good lot of dissection, unlike open, you should dissect from below so that you can get a better vision. So that is the second branch of segment 5. So both have been dissected from below. The first branch of segment 5 is being divided, 2 clips on either side, especially you can dissect off a good length so that you get good stumps. So there go down as low as possible and get into the precaudate plane. So there you see there is a second branch of segment 5 which has been so nicely looped up. So now this upper part above the segment 5, anterior part, there are no vessels. You can actually transect that in a hurry. So there, whenever you get a ductal structure or pedicle, you need to clip it. So this part you can, so if you have mobilized the liver well, you can actually pull down the liver so that the segment 8 area becomes much better accessible. You can see that while pulling down both side retraction, the entire segment 8 is actually come down, entire thing is become much more accessible. So that is the segment 5 second branch which is being dissected off from behind. Entire window is opened up and clipped on either side and divided. They are small branches, they do not need reconstruction, only the first one was big. So now going down, segment 8 especially you should be able to approach from behind posteriorly. So that is the upper end. The bleed is quite comfortable. So the entire blood loss most of the time is actually less than 100 cc. So there you're opening up the posterior plane, go as down pre-caudate area, open up right till the top. In fact, open up the area. So that's the segment 8. Now you can see it, it's actually pretty high. So there again, clip it, divide, and there you finish the dissecting off. There's hardly any bleed there. The entire area, the entire dissection is much better visualized. Now that's the cutting of the caudate. The previous dissection had already been, so that's the gold finger which is being passed through that, and there in the upper part using CUSA you can actually delineate the upper end of the duct. Now pass in the previously passed Riles tube through that window, so that is the hanging maneuver. So here the posterior caudate plane has been so thinned that there is only very little fascia left. The posterior capsule of the liver is only left, so which you can actually divide at this point. So this barely takes a few minutes. So that's the last part of the dissection. So that's the posterior capsule being divided off with the harmonic. So that actually finishes the transection. Now it is division of the duct. Now the last step is ductal division. So there you just now saw the caudate was being divided. So bile duct has been looped. Then you open up the plane between the portal vein. Now with the help of ICG, the duct is well delineated and cut under vision. So unlike open, here you have much better control. You know where exactly the right duct is joining the common hepatic duct, so that you can get a much better stump as compared to open. Now safety is the most important thing. Very rarely you may have to use Pringle. We have crossed about 350 cases. We have hardly had to use Pringle twice. So, but especially in the initial part, keep the entire hilum looped so that you can Pringle if required. In the last 4 years, we have done about 350 cases. We have crossed 350 cases. When we finished 300, we compared our laparoscopic 300 with the open 300. There were about 15 robotic also in this, which has been included. It was not actually removed from this table. So you can see the biliary complications are actually described more, but most of them were minor leaks. Since we were doing drain bili very frequently since we started minimal invasive, that's why we picked it up. The drain bili was actually slightly higher, and most of these cases was not as per definition of bile leak. It was just barely high. So most of them were treated conservatively. Only 4 patients needed ERCP, whereas 5 needed in open. Drain removal, since we were going by drain bili, the drain removal was a bit late in the laparoscopic group, but the patients were actually discharged earlier and it was removed on OPD basis. Remaining all complications have been similar to open. Presently we are able to do the laparoscopic donor hepatectomy in about less than 200 minutes. Initially we used to take about 6 to 8 hours. So I would conclude by saying minimal invasive, the numbers are increasing. Experience, preparation and planning is very much important. More and more centers are into minimal invasive donor hepatectomy. The patient acceptance is much better. Good instrumentation and teamwork is the key. Train well. Experience, especially in open, is very important when you are going on to minimal invasive donor hepatectomies. You need a good anesthesia backup, low CVP, and be ready with all preemptive measures. Thank you very much.
Should we move on to Gaurav's talk and then do the discussion, or?
I think, sir, if we can have the laparoscopic discussion now, if that's fine with you, sir.
Yeah, yeah, absolutely.
Thank you, Menon sir, for a beautiful video, sir. We being kidney surgeons, sir, it was a treat to watch such a clean liver surgery. But sir, the chair is yours, sir. Abhidip sir, Gaurav sir, sir. Any comments, sir? Bala sir, would you like to have any comments now, sir? Before
It is just that you need good open experience before you actually venture on to any of these minimal invasive surgeries. So with time you tend to improve, especially in the laparoscopic one. Robotic, the initial after 20-25 cases, you become actually very comfortable. But laparoscopy, you need at least 70-80 cases before you can really reach a level of experience and say comfortably that I can do it. Over the last maybe about couple of years, we have not had a single conversion, but that took us a long time.
Yeah. So, I mean, as always, Bala does a great job, and I've seen some of his video where he has shown troubleshooting in various difficult scenarios. So I think it is not just doing the procedure minimally invasive, it is your capacity to handle the problems which can arise anytime during the surgery. I mean, some initial few surgeries you can be lucky and you can safely do that. But I think the real success happens when you are able to manage if any inadvertent issue that arises. Because this surgery we are talking about a donor who's a healthy individual who does not require surgery for himself or herself. So I think one thing which Bala has rightly pointed out, that a number of cases which is required to achieve a proficiency, and then there is another set of cases you need to reach a level where you're able to reach the level where you can handle all the complications. I mean, various papers have been talking about that level of experience. The QSUM analysis says your time starts to come down after 35, 40, but the expertise to handle all the complications usually comes down anywhere between 120 to 160 cases. Correct me, Bala, what do you think about this? Maybe, I mean, some surgeons can achieve that in 40, 50, but some might require. So an average thing, what they say is, if you're talking about all kind of anatomies, when you can say this donor can be done similarly, lap versus robot versus open, depending on what you want to do, there has to be a level of proficiency which you have to gain.
Yeah, I totally agree. You need about 200 cases, especially when you have a bleed from the right vein, you have a bleed from IVC. So, to be able to tackle all those, you need at least 200 cases. And somehow, I have always felt tackling a complication is more easier with laparoscopic rather than robotic. In robotic, if it starts bleeding, then it becomes a bit dicey and difficult. But laparoscopy, you have a lot of choices when there is a complication. Yes, it's very difficult to treat.
Right. Are there any questions or comments from the participants?
Gaurav sir, any comments on this presentation, sir?
Oh, I mean, it was an excellent demonstration. Only thing is, the laparoscopic donor hepatectomy experience is limited to a few centers because you really need to be a very experienced skilled laparoscopic surgeon. And other thing is, Sirth is doing it very fast, but ergonomically it is taxing. So I think these are the only two comments which I have. Replicability wise, if you see the literature also, I think robotic is easier to replicate. You don't need to be a skilled laparoscopic surgeon. The suturing is also easier with robotic. But there are pros and cons. I mean, I think Bala sir is a very skilled laparoscopic surgeon and it is very easy for him to do that surgery. I think, I don't know whether, because if you see the literature over the years, the experience of robotic has gone up and laparoscopy has stayed the same to a few select centers all over the world. So I
I
think one
think,
is
sir,
the skill set,
ergonomics.
second is the ergonomics because it's a long surgery and
sometimes, I mean, depends on the dynamics of the team. So after you finish the donor, you have to go and do the recipient, and you have to keep on doing the same surgery day in and day out, day after day. So I mean, robotic, at least what I think is you get less tired at the end of the day. You are able to do the surgeries repetitively.
So, Menon sir, I mean, because this platform is basically to train the youngsters and somebody who's trying to pursue this subject, what would be your tips and tricks, sir, if somebody wants to pick up laparoscopic donor hepatectomy? Of course, the learning curve has to be, somebody has to undergo the learning curve, join a team. But what would you suggest, sir?
I totally agree with what Dr. Gaurav has said just now. For somebody to be doing, for me, actually, it took about 5 years to train the next guy. So it's a very long training for a guy. I mean, for a guy who actually had no advanced laparoscopic training. So what I feel is someone who has been doing advanced laparoscopic work like esophagectomy, LAR, APR, even pancreatic vaginostomies. So those sort of people can come and learn fast. But for a fresh graduate, for a fresh guy who has come out of liver training, it will take at least 3 4 years to get some level of experience of laparoscopic donor hepatectomy. But robotic can be easily picked up in a couple of months, depending on the case volume. So learning wise is extremely difficult, but once you have learned it, it definitely is cheaper, much faster, and maybe I totally agree that it has not really picked up worldwide, because by the time you come into transplant, you hardly have any laparoscopic experience these days. To pick up this procedure is actually difficult.
Yeah. Because HPV and liver transplant surgeons have always been maximally invasive. To actually shift to minimally invasive was as it is a challenge. So it was very few people who were trained in minimal invasive surgery, particularly laparoscopy. And so it is, I mean, when you see Bala's video, you feel it's so easy. But I can tell you, I mean, our experience, we started with laparoscopy. But then once I shifted to robot, I mean, I thought I'm not going to go back to laparoscopy. I was much more comfortable doing it. And I mean, it was, I mean, because I am not trained in advanced laparoscopy. So for me, the learning curve was even faster. But then that experience did help me when I shifted to robot. But I think if you have best of both platforms, I mean, someone who can do both like Bala, it's actually the ideal situation. But then uh, I think people who have not had experience in minimally invasive, my thought is my suggestion would be to look at robotic as an option if that is available in your program. And I mean, now it's high time that we should start looking at developing a model in terms of the proctorship model, in terms of how the next generation can get trained in minimal invasive donor surgery. We can look at the models which have been done by American Urology Society, where they train people in doing robotic prostatectomies. These many cases you have to observe. These many cases a proctor will make you do, and this is how you split the steps. So most important thing, if you look at Bala's video as well, so best way to learn a minimal invasive surgery, or for that matter any surgery, is you split the entire procedure into steps and keep on repeating the steps in the same way. And that is very important for the minimal invasive donor surgeries. Ravi is here.
If I am
Hi.
asked to compare
Sorry.
both the procedures, I always thought that doing the IVC and the hilum was much easier with robot. But
Yeah.
the recipient, the transection
Parenchyma.
is where
Yeah.
laparoscopic surgery scores. What you can
Yeah.
do with laparoscopic transection, you can actually finish it off in less than half an hour most of the times. But the same thing with robot actually takes maybe about a couple of hours.
So
So
once you
that's
have a CUSA for the robot, then that debate will be end over.
yeah, that yeah, I agree.
Or what we do is like a two surgeon approach in robot, where a bedside surgeon does the CUSA and the console surgeon just retracts. So that way it provides that safety, comfort, and but then I keep whenever I talk about this, people say not many programs would have a luxury of having those many surgeons. I mean, fortunately, we have that possibility where we can have two surgeons, two senior surgeons doing a donor surgery.
So, Ravi sir, welcome.
Thanks.
Sir, Bala sir just showed us a demonstration of a flawless donor hepatectomy done laparoscopically, and everybody is in awe of the way, the ease with which he has shown such a complex surgery. So, your comments on lap donor hepatectomy, sir?
Yeah, so Bala has this knack of also showing some of his complications during surgery, and once you see that video, then you're going to get really scared. But he does a good job of even managing them. So lap is again lap versus robotic is going to be a debate for a few more years. But obviously the advantage is that you have slightly lesser cost with lap, and then availability of lap is almost ubiquitous now, whereas robotic is not available everywhere and it's a little more expensive. Having said that, if you're transitioning, like Abhideep said, if you're transitioning from open to minimally invasive, robot is you'll find it easier. I mean, Bala has been doing lap, advanced lap for what, 20 years, although he's only 25 years now.
I think you I think you got the figures totally wrong.
Bolte sir, any comments from you, sir?
Uh, no, it was a treat watching this surgery, and the comments also have raised my curiosity now, because we have now two chairpersons who have exposure to both laparoscopy and robotics, and both have a say. Dr. Abhideep said given a choice, probably robotic would be a preferred thing, and as Ravi mentioned robotic would take certainly almost 2 or 3 times longer to do some certain step of this procedure that laparoscopy could get over within just half an hour. And even our speaker, Dr. Bala, he said if a complication occurs, the laparoscopic is a much easier thing to deal with. And Robo, I hope he will probably slightly explain it to us. But if it is something merely that undocking of the robo would take a lot of time, then I think that's it. If there is something else that is more advantageous, he can please explain a bit.
Only in situation of bleeds you are actually able to tackle it much better laparoscopically, although I think a lot of people who have been doing good numbers may not agree to it. One other advantage which I found was if there are multiple ducts, I feel comfortable doing it laparoscopically rather than robotically, because you can do a intraop cholangiogram much more easily. You can do the same thing with robot by just undocking and pushing it back and doing it, but that takes a lot of time. So basically, experience is what counts for laparoscopic surgery. Robot is much easier, more user friendly, and probably should be the choice.
Right, right. So I think now we can listen to Dr. Gaurav also, and then subsequently at the end of it, we can probably have more questions for both of them.
Right, sir. Gaurav sir, the stage is yours, sir. Please go ahead, sir.
Yeah. Are you able to see?
Yes, sir. Yes, sir.
Okay, so initial few slides are just about the evolution of MIS. It has gone through mini laparotomy and then laparoscopy assisted, then the hand assisted, then laparoscopy and then robotic. And then these are some of the consensus statements how laparoscopic liver surgery evolved, and then finally reached the stage of laparoscopic donor hepatectomy after the Seoul conference in 2016. The challenges of laparoscopic liver resection are the resection of the posterior superior segments, major resections, reconstructions, and lymphadenectomy. And the advantages of the robotic surgery are more degrees of freedom, better surgeon ergonomics, as we had just discussed, better stability of the camera and vision because you are not dependent on the endoscopist, ease of suturing and controlling bleeding, and lower biliary complications. So this was the initial paper which came from Taiwan by Professor Chen, in which 13 completely robotic donor hepatectomies were done and were compared to 54 patients who underwent open surgery. And the blood loss and complication rates, recovery of liver function was similar. Although there was a longer operative time and lesser post-operative analgesia, but the return to work was faster. And then the robotic donor hepatectomy experience increased and evolved. And then this is the paper from Professor Dieter Broering's group of 500 robotic donor hepatectomies from King Faisal Hospital, in which you can see that the blood loss was minimal, around 60 ml. The operative time was around 7 hours. Length of stay was 4 days. And the recipient survival, the biliary and vascular complications are almost similar to open. And then the experience increased further, and this is a study of around 3,500 cases, in which 600 open cases are compared to 165 laparoscopic and 900 robotic surgeries. And you can see here that actually the donor morbidity and the recipient morbidity is much lower in the robotic surgery arm as compared to both laparoscopy and open surgery. And one of the criticisms of laparoscopic surgery is the increased rate of biliary complications in the donor and the recipient because of the technique of dividing the duct. And this is a video. I'm going to show you two videos. One is a robotic left lateral in a complex anatomy, and second is a robotic right donor hepatectomy. So this graft had three arteries, two segment 4 arteries, and one segment 2 3 artery. And we start with lowering of the falciform ligament and then the dissection of the groove between the left hepatic vein and right hepatic vein. And this is division of the gastrocolic ligament, and we take down the arrhenius ligament. Then we come down to the liver hilum, and we start off with dissection of the arteries. We dissect off the segment 2 3 artery, and in this case you can see two small segment 4 arteries which are arising from the right hepatic artery. And this is the dissection of the left portal vein. We loop the caudate branches, ligate them, and clip them, and then we encircle the left portal vein. And we use the harmonic for parenchymal transaction for majority of the parenchymal transaction. The advantage is it is completely controlled by the console surgeon, so it is much faster. And sometimes in soft livers it is much less woozy. You can see that the field of the parenchymal transaction is very clear, and we go on till the very end till you get the left hepatic vein. That is when we switch over to the CUSA. Our use of the CUSA has become less and less now, and we are able to do almost 90% of the transaction with the harmonic scalpel. We use a Pringle when dividing the duct because the hilar plate is very vascular, and with the help of the indocyanine green, we see the junction of the right and the left hepatic duct, and we then divide it. And then we use the hanging maneuver from a caudocranial direction and go on to the left hepatic vein. And then we ligate the arteries by taking a tie and clipping. And then for the left lateral segment graft, we clip the left portal vein and we staple off the left hepatic vein. And then the graft is bagged and then retrieved through a phalangeal incision. And then we suture the duct. We have changed our approach from clipping and cutting to completely cutting and suturing, because this is a much cleaner way of handling the duct. You are able to get a good size duct, and the biliary complications are lower in the recipient is what we feel. And this is a video of a robotic right donor hepatectomy. This is a standard arterial anatomy, a single right hepatic artery, a short portal vein, a type B, and then no inferiors, a big segment 5 vein and a segment 8 vein, and a standard A1 B1, that is a single right hepatic duct. So this is our port position. We use four robotic ports along the line of the umbilicus and two assistant ports, one in the midline in the epigastrium and one lower down. And this is the first step. We dissect the right hepatic vein groove between the RHV and the middle hepatic vein. And then we start off with mobilization of the liver. Again, it takes place from a caudal to cranial direction. The assistant grabs the gallbladder and rotates it medially, and then we go from caudocranial, and the robotic arm, that is R4, retracts the liver, and the combination of R1 and R3, we dissect the liver of the retroperitoneum. We then go on to the cava. The short hepatic veins are clipped, ligated if we encounter a big or a significant right hepatic vein. At times, we also need to staple it. If we can preserve it, we try and preserve it. So it depends upon the location of the inferior vein. This is dissection of the right hepatic vein groove, and then we pass the Foley's for the hanging maneuver. We never try to loop the right hepatic vein robotically, because there is a risk of injuring the right hepatic vein. We come off to the liver hilum. We start off with doing the cholecystectomy, and then dissection of the right hepatic artery and right portal vein. The choice of instruments is completely surgeon dependent. You can use the monopolar scissors or the Maryland bipolar, depending upon the comfort. Sometimes this is, as Bala sir had said, the dissection of the triangle. Sometimes it is difficult to loop a short portal vein, so we don't necessarily loop it. We just put a bulldog by completing almost 75% of the dissection. And this is the indocyanine green technology which we use for clamping. And then again, we use the harmonic scalpel for majority of the transaction. And in the deeper parts, we use the CUSA. So once you have opened the liver sufficiently and you have identified the segment 5 vein, usually you get a segment 5 vein near the liver hilum, and we use that as a landmark and then finish the parenchymal transaction. We don't finish the entire caudate transaction in the beginning, because sometimes you get a large terminal segment 8 vein, and you may injure it if you want to finish it in the beginning. And this is again the use of the indocyanine green. This was initially, in our experience, we used to loop the hilar plate and clip and cut the duct, which we have changed now. We have switched to cutting and suturing. And then this is the last part of the parenchymal transaction, in which we hang the liver over the Foley's. And again, we use the CUSA or the harmonic to finish off the caudate transaction. And then this is lengthening of the hepatic artery and the right portal vein. We clip it and cut it. If you have a long right portal vein, we put clips and cut. If you have a short portal vein, we use a stapler across. And then the RHV is stapled, and the graft is bagged and removed. And then we fix the liver by suturing it to the anterior abdominal wall. And this is our experience so far from the last 2 years, from 2024 to 2026. We have finished 187 robotic donor hepatectomies, out of which majority were the right lobe. And this is the QSUM analysis. When we compared the robotic arm compared to the open arm, when it came to the donor surgery, we can see that the length of stay, the blood loss was lesser as compared to the open surgery. Initially, the time taken for the robotic surgery was around 7 to 8 hours, which has now come down to a console time of around 4.5 hours. The transaction with the harmonic scalpel, actually, we have become faster with time, and we're able to finish the transaction in around 45 minutes to an hour now. And this is the recipient outcomes, again, you can see that the overall survival was identical to the open surgery, and the vascular and the biliary complications, especially the vascular complications, were lesser with the robotic donor hepatectomies. And now, as we all know that we are moving towards the robotic recipient surgery, and a couple of centers have started doing it. And I think the largest experience again has come from King Faisal Hospital from Professor Dieter Boring's group. When I last heard him, he had completed more than 10 robotic recipients. And so to conclude, I think the safety has been established of both laparoscopic and robotic donor hepatectomies. Stepwise approach with gradual increase in the difficulty level is helpful. In the beginning, I think choosing the cases, smaller grafts with standard anatomies is a better way to go about it. Again, as Bala sir also said, you need to be well versed with liver resection. You need to be acquainted with the differences in open and MIS. It is, I would say, it is not a replication of open surgery for me at least. You have to reorient some of the concepts, especially the caudal to cranial approach when it comes to liver mobilization, the medial to lateral approach. And then again, when you're doing the parenchymal transaction, you are going from a caudocranial direction, which is opposite to that of open surgery. So especially the robotic transaction with the help of harmonic, you have to reorient and relearn the principles of the open transaction, because in open you use a open book technique as opposed to a open door technique in the harmonic transaction. One of the most important things is your OR team. It should be constant and it should be developed, because in the beginning the operative time is long, and often there is fatigue of the OR team, which you need to overcome. So it requires persistence and a lot of motivation. Uh, but it is doable. Once you start overcoming the learning curve, it actually becomes a enjoyable surgery, and you feel like doing more and more of the robotic surgeries as opposed to open. Because when you see the donor outcomes, it is very gratifying. The donor is able to recover much quicker with better cosmesis and lesser pain.
Right. Thank you, sir. Abhidip sir, over to you, sir. Your comments, please.
Yeah, nice work, Gaurav. So, I mean, these are important things which you pointed out. In the beginning, it is important how you develop a team, and every team member uh, gets an idea about what the steps going to be, because from open to minimal invasive, once you change, there is obviously bound to have a longer duration, and there is some modification in the steps till the time that harmony come with the team members. It is sometimes there's a confusion, and that is something uh, regular discussions on that aspect helps, and making people understand that it is going to be a little longer in the initial part till you actually reach your QSIM level, and then you are uh, improvising on that. So, I mean, again, as I was saying earlier, I mean, it's a donor surgery. It is the benefit of this surgery should be more than what you have already achieved when you are doing open. So then only it makes sense. So it is not a cosmetic surgery we are doing. It is basically a life-saving surgery for the recipient and a noble act of the donor, where the idea is not just modifying the incision. Definitely, if we look at the long-term data, 28% of the donors complain about the wound related problems, and that actually is taken care by minimal invasive, whether it is lap or open. But then, more important than that is these procedures should look at improving the outcome. And as the recent articles are coming in and more experience data is coming in, as Bala has also pointed out, it is you get better quality ducts and vessels with minimal invasive surgery. So it is actually not just the change of the incision, but also getting a better quality graft, and the recipient problems also reduce with time. That is something would be a real gain. And I think we are getting there. Only thing now we have to look at how we develop these training models as well, where the same things can be percolated to other center. India is doing highest number of living donor liver transplants in the world. I mean, way higher than any other country. I mean, to talk about the figures, we did more than 4,000 LDLTs in 2025. And the next highest done by another country is close to 1,400. So we need to look at, I mean, the world is looking at how the Indian LDLT program is evolving. And we need to keep in mind how safety can be maintained and how these techniques which we have learned, we are able to pass it on, and we are able to develop good teams doing these procedures even better than what is being done right now.
So one of the things here is that LTSI, of which Avideep is the president currently, runs a very successful liver transplant fellowship, and I think, I mean, it just occurred to me that we should consider offering like a minimally invasive donor surgery fellowship. Not, I mean, after somebody is a transplant surgeon, like established transplant surgeon, that will help a lot of people because right now it's concentrated in about 10 centers, but there are a lot more, many more people who would want to do it.
Yeah, kind of agree with that.
So my comment is that in a MIS fellowship, giving hands-on to a fellow in 2 years may be a little difficult because
Hmm.
normally you are training the next senior most person
Hmm.
next to the senior surgeon in these procedures.
Yeah.
So it will be more of a observational fellowship.
That everybody does. I think that it has to be for people who are at least 5 years into transplant or 5 years doing LDLT, something like that. So then you could basically get good help from them because they are already experienced, and then they will also benefit because they will be able to do it actually.
Only, I mean, robotic, I would say that in the beginning, you have to be extremely cautious, and
Hmm.
the whoever is doing the robotic donor has to be a really experienced open donor surgeon because the margin of error is very small here because the
And you.
liver graft is sometimes very soft and just
Hmm.
handling the liver applying too much compression and all can really lead to uh,
Yeah.
poor outcomes in the recipient.
Hmm.
Also, the transaction when you're doing using the harmonic, the way you blend it, and those are, I mean, you really
Yeah.
need at
Yeah.
least 6 7 years, I feel, of
Hmm.
open surgery.
Hmm.
I mean, it is with good mentorship, I think we'll eventually get there. But I mean, it is a difficult surgery to overcome the learning curve. I mean, it took us a
Hmm.
long time. It took us almost 2 years to overcome the learning curve.
Yeah.
I mean, we were at it, and at times it was frustrating. The team members were losing patience. But then finally, we were able to do it.
Hmm.
Sir, doing hepatectomy for other indications, does that help in the learning curve for a donor hepatectomy? I mean, you could
Absolutely.
offer a surgeon a donor hepatectomy after a training of the hepatectomy for other reasons,
Absolutely, it helps.
right,
Yeah.
sir? I mean, it's the other way around for kidneys, actually, if I may say so. Doing a simple nephrectomy for infective causes is much more tougher. I'm
Yeah.
talking about laparoscopic, as compared to a donor nephrectomy. Doing a donor nephrectomy has a much lesser learning curve as compared to for other indications, say for neoplastic reasons or for infective reasons. Is the other way around in kidneys at least. Uh,
Yeah.
right. Then, sir, your comment, sir.
Yeah, I agree that doing a lot of these non-transplant surgeries will help, especially if you are planning laparoscopic. Robotic, maybe you can straight away go in and start doing, if you are experienced, you can straight away go in and start doing donor hepatectomies. But laparoscopic, since the learning curve is quite a long one, maybe resections for hemangioma, right hepatectomies, left hepatectomies. So those sort of things, yes, for laparoscopic surgery, it's going to help.
Right, sir. And oftentimes, no, you don't get the, especially, I mean, the volume of resectional liver surgeries is comparatively lesser as compared to the
Yeah.
transplants, because the majority of the tumors occur in on the background of chronic liver disease. So you don't always have the luxury of doing a lot of robotic resections. In fact, the first robotic liver surgery which we did was a robotic left lateral donor. So, I mean, in Indian centers, I don't know how much you'll be able to bank on waiting for the experience to develop the robotic non-donor part.
Hmm.
Yes, congratulations, sir. Gaurav. Good, good.
Bolte sir, any comments, sir, here?
A lot of things depend on the interest.
It was really very enlightening to hear these thoughts. And as each of them said, that uh, the morbidity and the cosmesis part is really very uh, much more in robotic and laparoscopic surgeries. Now that our Indian subcontinent being a leader in the live donor transplant surgeries, do you have any data or any series wherein the safety profile also has been compared between open donor hepatectomy and the minimally invasive techniques? The mortality part.
Yeah, Indian, I think the papers are there from Amrita and then Vedanta and also from Dr. Rela's group, in which I think the outcomes, especially what I think Amrita group had shown, is the outcomes are better as compared to open surgery. The same has been shown by Professor Dieter Broering's group also in the large series which they had shown of almost 4,000 cases, that robotic compares better than open and laparoscopy when it comes to outcomes in donors and recipients. One of the major advantages of the robot is you get better quality of ducts, and that reduces the biliary complications in the recipient.
No, my specific question was with relation to the mortality part.
Yeah.
Is minimally invasive surgery, mortality wise, any way more advantageous than the open donor hepatectomy?
So I think currently whatever literature at least which I am aware of has not shown any mortality in the robotic group at least.
Hmm. So here I would say that we are generally aware that the mortality is underreported in India, the donor mortality. The safety profile is obviously published well in terms of complication rates, in terms of donor and recipient complication rates. But mortalities have not be have been underreported in India for both kidneys and livers, and it would be sort of incorrect to say that just because it's not reported, it hasn't happened. So I think that the to be fair, we have to say there have been some donor mortalities all across the world related to minimally invasive surgery, and they have probably not been higher than what was reported during the early part of open donor surgery, like about 10, 15, 20 years ago. But again, they are underreported.
Bala sir, I think you were trying to say something, sir. Menon sir, your mic is on mute, sir.
Oh, yeah.
What
So
exactly?
what I was saying was actually regarding non-transplant surgeries. So since we do quite a lot of these non-transplant resections, because AIG is basically a GI center. So child's A, child's B patients coming for laparoscopic surgery probably have much better survival and fewer complications. So there I have found a big advantage.
Okay. Right. So, Gaurav sir, thank you so much. Again, complex surgery, very, I mean, you made it so smooth and such a luxury to watch. Um, so, thank you to both the speakers, sir. Sir, Abhideep sir, any last comments from you and Ravi sir before for the two talks today, sir?
No, it's actually good to have session like this, and actually, people who would uh, see this would definitely learn intricacies, not just the surgical part, but also the discussion around the minimal invasive donor surgery. And and since these are evolving fields, there are a lot of pros and cons that needs to be discussed. And I think these kind of sessions would help a lot of upcoming surgeons to get a benefit of learning from these sessions. And I congratulate ISOT for conducting these sessions, and I think we should look at doing some joint sessions with LTSI in the coming times as well, on a common selected topics, and which can have a wider reach and more people can get involved. Thank you for having me.
Thank you, sir. So that is actually the intention of a program like this. So basically, for the young ISOT members who are trying to find their way through these transplant science, just to motivate them, give them some food for thought, and learn from experts like you guys, um, uh, and start finding a way through the difficulties which they face in their careers. Sir, this session would be available on the YouTube ISOT page for anybody who would want to go back and have a look again at the videos and have a look at the discussion and then probably have some tips and tricks again from them. So thank you, Abhideep sir, for joining in. Ravi sir, your comment, sir.
Yeah, so I think this is a very good platform. So far we have been doing this and similar workshops in and webinars in LTSI. I think this should just be a trigger for us to collaborate much better. And
Right,
we
sir.
should do joint sessions not only in online but also with jointly in our conferences. So there could be like dedicated sessions manned by LTSI in ISOT and vice versa.
Definitely, sir. Bala sir, Gaurav sir, your last comment, sir.
So thank you very much for having me. It was a pleasure. Thank you. Thanks a lot.
Thank you, sir. Thank you. Gaurav sir. Gaurav sir, somebody was congratulating you. So I think you owe us one more explanation, sir.
That was for
Apart
something
from the
else.
great surgery that you showed us.
No, that was for something else. I'm actually sitting in the OT lounge. No, so it
Right,
was
sir.
great learning. I mean, I loved the videos and the discussion. I think, as Ravi sir and Abhidip sir has also said, I think this is the way to go for sure. Only thing is we have to tread carefully because this is a donor surgery and the margin of error is actually very small. So, I mean, once you overcome the learning curve, it becomes very enjoyable. But that is the actually critical part, as is for all surgeries.
True, true. Right. So thank you, Gaurav sir. So I think with this, sir, I thank the two chairpersons and the two speakers for such a great session. And on behalf of ISOT, I think we've lost Pulte sir's network. So on behalf of ISOT office, I thank each one of you and the attendees who attended this. And for people who could not attend and who are watching us retrospectively on YouTube now, thank you for joining in. And thank you again to all the esteemed surgeons here. Thank you so much, sir.
Thank you. Thank you, everyone.
Thank you. I think we can sign off with this, sir. Thanks a lot.